Hello and good evening everyone. This is Dr. Kartik from Asha Neuromodulation Clinic. So thanks to everyone who has already joined. So I think I'll just brief whoever is already here about our TMS technology and its applications. So today's theme, as you can see, is Deep TMS and its applications in mental health. And we welcome all who have joined in this live session. So for a brief introduction of TMS, so it's a third modality these days. So as we know, earlier modalities of treatment, for example, if we have to treat a mental health condition, the earlier options were medication and psychotherapy. Now we have a third option in the form of neuromodulation, out of which TMS, which stands for transcranial magnetic stimulation, is a third method. And this is a different and a new technology which we feel has been relatively underexplored in the last few years. So to give you a brief kind of background, the research on this started in maybe the late 80s or early 90s, and the technology came into commercial use in around 2008. Right. So, and from then we have used it for various conditions in the treatment of various mental health conditions, depression being the predominant one. So we have around 15 years of long-term data with the help in terms of safety and in terms of its effectiveness in the treatment of mental health problems. So coming to Deep TMS now, this is a relatively newer technology. Earlier we had RTMS, which was repetitive transcranial magnetic stimulation. To give you a bit of background on that, it involves stimulation of targeted brain areas. So this stimulation is non-invasive, and which means that there's no surgical procedure involved in this. We are not entering or piercing the body in any way, and this non-invasive stimulation involves placement of a coil on some region of the head which targets a specific brain area. So the theory in this is that there are certain brain areas which are involved in key networks in the brain which control our normal functioning of consciousness, like say functions like our attention, concentration, motivation to do a task. So these kind of functions are controlled by certain networks in the brain, and when there is a stress on our brain or when there is a problem with these networks, we face certain symptoms, like the symptoms of depression, in which people don't feel like doing anything, or their mood is low, the concentration is low, they feel fatigued easily. So these are the kinds of symptoms which we see in common mental health conditions. And the basis of TMS technology is basically that we stimulate certain key areas involved in this, and we try to activate those areas and get the functioning back to the baseline or normal level of functioning. So this is a bit about TMS, and earlier we had RTMS, which was more superficial level of stimulation, and now there have been different technologies developed, one of which is Deep TMS, in which we can target deeper brain structures also. And this is supposed to lead to increased efficacy with relation to the treatment of common mental health conditions. And right now we are doing it for three main conditions, which is 3 or 4 main conditions actually. One is depression with anxiety, one is nicotine dependence, and the other is OCD. So these are the 4 conditions for which this treatment is currently US FDA approved, and there are of course other indications for this as well, which we can discuss during the course of this session. So these are some of the basics about TMS, and I'll brief you a little bit regarding the procedure also. It's quite a very safe procedure. The dropout rates are the least when compared to any other modes of treatment for mental health conditions. And severe side effects, the incidence is very rare. Some common side effects can be expected, like headache, that too maybe in only 10 to 20% of the people who take this treatment, but otherwise it's a very safe procedure. And it's not invasive and it's not painful, so there is no anesthesia or anything that is required. There is no pre-procedure preparation required, and there is no post-procedure dedicated recovery time or anything like that which is required. So it's a purely office procedure which lasts anywhere between 18 to 20 minutes. And it's by nature not painful. There may be a mild tapping kind of sensation on the scalp, but otherwise it's not a painful procedure. right? And so this is some of the basics about TMS. And now any questions anybody may have are welcome, and we can discuss that in whatever level of detail the time permits. So please put your questions in either the questions or the comment section, and I'd be happy to answer any queries you may have. Yes, so we have one query here. What is the difference between TMS and Deep TMS? So TMS has been an older modality. It has been in use for quite a long time now. So the difference is that the Deep TMS has made us able to target certain locations in the brain which was not accessible with earlier TMS machines. So for example, there are some regions in the brain which lie deeper to the superficial structures and which are also involved in these key networks that we talked about. They are key networks which control various actions, and the disturbances in these networks can lead to symptoms of various conditions, even something like we mentioned, like say depression or OCD or anxiety. So when we are able to target some of these deeper structures, we are able to reach new targets in Deep TMS that were not previously accessible. So one of the things in clinic that we notice a difference is that with earlier TMS, the response to OCD was a bit mixed. The literature is also mixed. The evidence for OCD is a little mixed, but we are having a much better response with the Deep TMS machine. So this is the main difference, that there are new targets in the brain, the new regions in the brain which we can stimulate because of the increased depth of stimulation of Deep TMS. So this is the difference. I hope I clarified that query. Yeah, so we have a question about contraindications as well. So there are relative contraindications, not absolute ones. Some absolute contraindications will be if there is a ferromagnetic implant somewhere in the head and neck region or the brain, or these are absolute contraindications because there can be interference with the magnetic field can cause interference with the implant. It can cause disturbances in functioning. There can be thermal injury or dislodging of that, but this is a very rare scenario, and we have so far not encountered it in the clinic. And so far, if I talk about our clinical experience in the clinic, it usually we have not refused this treatment for many people, for anybody actually. In some cases, with dental implants or something like that, there may be a slight vibration kind of sensation due to which the patient is uncomfortable and prefers to discontinue. But otherwise, we don't have any absolute contraindications. And relative contraindications, we are more careful in certain cases. For example, if somebody has a history of seizures, we may decide to give anti-seizure medication before the sessions, start it for a few days and then give the sessions. In some cases, there are head injuries or things like that. In those cases, we are more careful. Dental implants, sometimes when there's a doubt about dental implants, we take the help of a dentist to find out if the implant will interfere with the magnetic field. So that is one scenario where we are more careful, and in some cases like say cardiac pacemakers or something like that, so there we are a little careful. But in all these cases, with adequate precautions, it can be given. So the only absolute contraindications I feel would be any implants in the head and neck region which interfere with the magnetic field. Yeah, so how deep do the pulses go than in traditional TMS? So around 2 to 3 centimeters deeper than in traditional TMS. That is the finding so far. So we are able to access certain targets in the brain which are not accessible with regular RTMS. Here we have another question. How safe is it in pregnancy? Yeah, so it's safe in pregnancy because the stimulation is only supposed to reach till the head and neck or maximum up to the chest region. So there is no interference with the regions below that. So there is no expectation of a magnetic field causing any issues with the pregnancy itself. In fact, it is a safe treatment in pregnancy. It can be accessed during pregnancy, and it is a safe treatment. There is no problem with giving TMS in pregnancy. There has been some research on this, and it has been found to be safe in pregnancy. Yeah, so the cost per session on average, that varies. It depends on the center to center. Usual cost in India is between maybe around 3,000 to 5,000 rupees per session, but that depends on various things actually. So it might be lower than that in different contexts, but this is the average one. Yeah, the sessions required is another important thing. So that again depends on the diagnosis. So For example, something like a depressive disorder, in our clinic we give 12 sessions. There are other protocols which cite around 20 sessions. This is on an average, and in OCD the number of sessions are required are slightly more. So for example, in our clinic we give 18 sessions for OCD treatment. Other centers give up to even 30 sessions or more. So these are the number of sessions required. It varies from diagnosis to diagnosis. And in anxious depression and depression, we personally give, in our center, we give 12 sessions based on our empirical clinical experience. So this is the regarding the number of questions. 2 sessions are there regarding the number of sessions. So I hope I have answered those questions. In nicotine dependence also we give anywhere between 12 to 18 sessions, and that is actually that's a flexible parameter for those asking. So we can always extend the number of sessions to a higher degree, and some scenarios are there. For example, if we are giving 12 sessions for somebody with a depression problem, and the improvement is coming only at the 9th and 10th session, and by the time we have reached 12, there's only a partial level of improvement, say 30 or 40% improvement, but there's a definite change. So in those scenarios, we are very much free to extend it to 20 sessions if we have the consent of the person we are treating. And we recommend extending sessions in those particular situations to extend the benefits of TMS. So I hope those questions are clear. So there's one question: does magnetic stimulation have side effects? So there are minor side effects in some people, but overall it is a very safe procedure. So when we do it in the clinic, the experience that we have is that about 10 to 20% of the patients develop a headache in the first few sessions when they are not used to the treatment. But this headache is temporary and it is related to the procedure itself, and it does not require any specific treatment by itself, and it usually goes also by itself within a span of around 1 to 2 hours. We have hardly seen any instances where the headache has remained persistent. We have not seen anything like that. Some people complain of mild lightheadedness or dizziness, again related to the session, which again resolves by itself. And these are the common ones. Very rarely in literature throughout the world in the last 30 years there have been some 40-50 cases of seizures, but all of these people, most of them have had prior instances of fits or seizures. They've had prior instances of head injury or regular alcohol consumption or something like that. There was always a risk factor which was associated. In India, we have hardly any reports of any fits or anything. In our clinic, we have not had any cases so far. So I hope that answers the question about side effects. And in any of these questions, if you have a follow-up question, please feel free to post it. And so I have another question what is the long-term improvement in patients who do respond? So here there is the evidence in the literature says the effects of TMS last for 6 months to 1 year, but there is a variation in this, like a variation with most other treatments. So some of our patients who have taken TMS, many of our patients are maintaining well. Some of them have had to come for maintenance sessions whereby we give maybe 2 sessions a month for 2 or 3 months after the main course, and this continues for a while. In other patients we just use medication to maintain the benefits that have accrued from TMS. We so far in our 1.5 years of deep TMS, or about 1.5 to 2 years of deep TMS experience, many people do maintain this, but in most people the caveat is that we also use medication. So, and in individuals in whom we have only used TMS, many of them have maintained, some of them have relapsed with their condition, but there are other factors which are involved in the relapse as well. So I hope that answers that question about the long-term improvement. So specific trimester in pregnancy or any trimester. So here there's no contraindication, or there's no restriction to in which trimester we use this treatment, because we don't expect any fetus or feto-maternal interactions with TMS. We don't expect it at all. There's no placental or feto-maternal interaction at all. So there's no trimester restriction as such. You can use it in any trimester. And the specific profile in pregnant patients who would respond, here the indication is mostly clinical. There's no difference in pregnancy. So the situations, so this is a good question, because it helps me to bring out another aspect of where exactly do we use TMS. So for example, if we have 100 cases of depression or OCD, Do we use it in everybody? No, we don't use it in everybody. We use it in specific clinical situations. So the first one would be if the medication is not fully effective. There is some part of symptoms which remain despite an adequate dose and adequate duration of medication. So second instance where we use it is where there is no improvement with medication. Another instance would be where people are not able to tolerate even low to adequate doses of medication. So if they're not able to tolerate low doses, we cannot build up the medication to an adequate dose. So in such a situation, we would use TMS. And another newer indication that we are exploring is when people require improvements in a relatively shorter kind of span. So the horizon of improvement with medication that we expect is over a span of weeks to months. So in TMS, we have seen that over a period of days, at least there is a minimum of partial improvement. So if somebody has a time limited restriction where they would like to get some benefits with some treatment before they have an important life situation coming up, that is one of the indications that we are currently exploring at our clinic. So in pregnancy, the profile is no different. I think it was the similar kind of conditions would apply to pregnant patients. Similar kind of diagnosis again, for example, depression with anxiety, OCD, all these conditions in these specific clinical situations when they approach us, we can give TMS in any of these patients. So interval between the sessions, yeah, this depends. So for example, you can give, so there are two different kinds of protocols. One is a regular protocol which has been going on for a while, which is 1 session per day. So in that, there's no question of interval. It's a minimum of 5 sessions per week in established literature. So you do one daily and the patient goes back. So this is a normal regular protocol with a minimum of 5 sessions per week, sometimes 3 to 4 sessions per week, depending on any clinical situation that may arise. Another type of protocol is something called an accelerated protocol, where you give more than 1 session per day. So in that, we advocate a gap of at least 1.5 to 2 hours between sessions to minimize the incidence of any side effects. And we have routinely given accelerated protocols. In fact, I can say that now in our clinic, accelerated protocols are probably more common than one per day. And we don't find any differences in the response or in the side effects. So I think it is, we have safely given accelerated protocols of 2 up to 3 sessions per day also. Without any issues. So I hope this answers the question of the interval between the sessions. And yeah, in many places the frequency is 5 sessions per week. Our clinic is open on Sundays also, so sometimes people take sessions continuously till the number of recommended sessions to them is over. So there is no gap sometimes, but if there's a gap of 1 or 2 days in between, that should not be a major issue. Right, so are we the only Deep TMS clinic chain in India? Yeah, chain, yes, I think we are the only ones. Yeah, so I think we are the only chain of clinics in India. We have centers in many cities, including Bangalore and Guntur and Vizag and many other places in India. So how is the efficacy in cases of substance use disorder? How has your experience been with them? Okay, yeah, so this substance use disorder, it has some caveats. So in established literature, the efficacy in substance use is not an established finding. There are some mixed results. We in our clinic have used it more for tobacco related dependence. The number of patients still has been relatively lower when compared to depression and other illness related TMS. Here the primary finding is that it is effective for craving. So, and it has to be combined with other strategies of substance use treatment, like for example nicotine replacement, brief interventions like motivational interviewing or a 1 session brief intervention. It has to be combined with something like this. We tend to combine it with the other interventions to make them more effective. But yeah, the sustained observation is that the craving for tobacco reduces. This is our experience with TMS for substance use disorder. Yeah, from a practical perspective, any idea how much a decent TMS setup would cost? Yeah, this is a professional question. So I think, yeah, there's a wide range actually. So I think that is a detailed discussion in itself because there are older TMS machines which started anywhere maybe between around 20 lakhs, and there are newer ones which cost up to much more than that. So it depends on a lot of parameters. For example, if there is the machine equipped to handle a certain number of pulses in a day, are other protocols, like apart from high frequency RTMS, there are low frequency, high frequency, intermittent theta burst. There are various protocols like that. So whether it is ITBS enabled or not, whether you can pair it with an EMG machine, there are various parameters for this. So the cost would vary, I guess, depending on the kind of machine you're wanting, the kind of illnesses you're targeting also. So for example, if you're targeting stroke rehabilitation, that may lend itself to a different type of paired pulse TMS kind of thing. So that would cost more than the usual one. So here we have another question. So is it used in addendum to medication, or can it be used alone without meds? Yeah, so that is an interesting question. So here in depression, the efficacy has been found to be almost similar to treatment as usual, the traditional methods of treatment, including medication and psychotherapy. So there is a chance to use it as a monotherapy also. So we can use it as a standalone treatment. We usually combine it with medication at our clinic. So because medication has also the advantage of being a very cost-effective intervention and also relapse prevention. That is another area, because neuromodulation interventions are time-bound. Basically, there's a time-limited effect to them. So we prefer to use medication at least in the maintenance phase. So when we have different requests from patients where they don't want to start medication early, or they don't want to take medication at all, so we try to find the best strategy for them among the three modalities that are available to us. That is medication, psychotherapy and TMS. So we normally advocate medication for the maintenance phase of treatment. But yes, in certain conditions it can be used alone, and we have used it alone also. We have used it alone in depression, we have used it alone in OCD, and we have seen good results in the initial phase of treatment. Data about TMS in postpartum depression, I'll have to look at it. I am not very sure of how much data is there regarding postpartum depression, but the safety in pregnancy has definitely been researched, and that is not an issue. So it is a good option in postpartum illnesses where medication might lead to certain precautions on our part. Yeah, time duration of one session and any prerequisite. This is another question. Yeah, so time duration of one session is between 18 to 20 minutes. That's the usual standard sessions. So there are different types of TMS sessions. So one is called there are low frequency sessions, there are high frequency sessions, and there are something called theta burst sessions. So I'll try to discuss each one of them. Low frequency session is something that will inhibit or deactivate one particular brain region. High frequency session, which is anything more than 5 Hertz frequency of the TMS, that is called a high frequency session that will activate or stimulate a particular brain region. And in theta burst again, there are two types of theta burst. One is called a continuous theta burst, one is called an intermittent theta burst. So here continuous theta burst deactivates, it is like low frequency TMS, and intermittent theta burst activates or stimulates. So that's similar to high frequency TMS. So here the difference is that low frequency and high frequency sessions usually last for between 18 to 20 minutes. And theta burst sessions usually last between 3 to 9 minutes, 3 to 5 to 6 to 9 minutes. This is the major difference. So this is the time duration. And prerequisites, can you expand on that question please? As such, there's no pre-procedure preparation which is required. And usually prerequisites is that we do screening for any kind of fits or seizures and any head injuries in the past. We screen for any risk factors that might cause any complication with TMS. That we screen for in every patient before doing TMS. So that screening I would say is a prerequisite, because we have to assess the safety of TMS in every individual. Otherwise, there's no prerequisite as such. But if you have any specific questions regarding any prerequisites, I'd be happy to cover that. Yeah, so we have a question about ECT versus TMS in terms of efficacy and side effects. Yeah, so here, nice question actually. Thanks for asking that. So this is a very common question asked in our clinic also. So when patients come to us, I have answered this question many times, that they ask that question, that doctor, is this shock treatment? So first, for anybody who's joining us, this is not shock treatment. That is called ECT or electroconvulsive therapy. And so first thing I would say here is that there is a difference in the indications itself. So the population in which we give ECT or shock treatments is not very similar to the population in which we select TMS as a treatment method. But it can overlap. Sometimes we can give TMS in patients in whom ECT is not a preferred option for the patient or something like that. So in terms of efficacy, in the limited literature we have, ECT is superior. There is literature is ECT is superior to any mental health intervention. Actually, it is the most superior mental health intervention. I think only lithium comes close in terms of efficacies. And but here the advantage with TMS when compared to ECT is that the side effect profile is much more favorable and there is no anesthesia which is involved. So in ECT, one problem is anesthesia. It involves anesthesia, so there is pre-procedure preparation required. You have to come without eating for a certain period of time, and anesthesia will be given. ECT is done, and post-procedure, a certain dedicated recovery time is there where a person is usually drowsy or sedated due to the after effects of the anesthesia. There's a relatively slower recovery from anesthesia. And the memory related side effects which are there in ECT, memory related side effects or muscle soreness which can happen sometimes, those things are not there in TMS. So headache is a common side effect, but which we see it with lesser frequency and lesser intensity in TMS than we see it in ECT. So these are the differences in terms of side effects, I would say. And if any more follow-up question to that, please, I will be able to answer that. So we have another question here. How effective is Deep TMS for OCD? So I can speak to our data here. So there have been studies since around 2019 where certain protocols have been used which has shown very good efficacy in OCD. When I speak to our data, most of our patients improve after 18 sessions, at least to a partial extent. And when we analyze the data, so we use a rating scale which is a questionnaire. We use a questionnaire basically. So this is our routine procedure, that we use a questionnaire before treatment and after treatment to measure if there's any change with the TMS treatment. And most of the time here, the medicine does not change during this time. There's no change in the medicine during the course of treatment. The same prescription is ongoing. And so I can tell you some recent data of ours. We see that questionnaire which we use routinely, which is called YBOX, Yale-Brown Obsessive Compulsive Disorder Scale. That is a 40-point questionnaire. So in that, if the initial score is around 25 to 26, on an average in patients coming to us, and on an average we see a 10 to 12 point reduction in those scores in about a span of 9 to 18 days. So we are quite satisfied with that level of improvement. Most of our patients are also satisfied. In some patients it may take longer, more number of sessions, and some may not have the same level of effectiveness. It really varies from individual to individual. But considering the long-term nature of a chronic and disabling problem like OCD, us getting an improvement in a short period of time is quite a satisfactory endeavor. So I hope that answers the effectiveness related question. Please put a follow-up if you would like to. Going to the next question. So like antidepressants, can it induce mania in those who are vulnerable? So does Deep TMS also have this risk? The theoretical risk is there definitely, but with any kind of TMS, the risk is very low. It's quite a very extremely rare event that an antidepressant like switch into mania occurs. There has been a recent review of literature on this also, and that risk is almost negligible in clinical populations. So again, speaking of practical experience in our clinic, in the center that I am in, so I am from Hyderabad, the clinic in Hyderabad, and we have not had any switch in our clinic so far. So would dental or jaw implants, metallic implants, be any cause for concern? That's a nice question, so thanks for that. And here so we have gone into some depth regarding this. So there are certain material, so here we can follow the template of MRI safety, because the strength of the magnetic field produced by the TMS machine is quite similar to what the MRI would produce. Sometimes say a 1.5 Tesla MRI would produce. So here there are some older varieties of dental implants which contain nickel chromium alloys and certain substances which are considered ferromagnetic. Even certain variants of stainless steel, nickel chromium alloys. So these have a theoretical risk of interference with the magnetic field, which includes, like I said earlier, dislodgement, thermal injury, any vibration kind of pain kind of sensations. But over a period of time, we have collaborated with dentists and a dental clinic near our setup, and we have overall managed to deliver TMS to most patients, even with dental implants, without any major issues. So over the span of 1.5 to 2 years, maybe there have been 2 or 3 discontinuations related to dental implants because the patients felt a small vibration or pain kind of sensation. But otherwise, we have been able to safely deliver. And sometimes the dentists have helped us very much. So we thank them also, where in cases where we had to remove a particular implant and the OCD was, for example, thought to be a more serious problem than the dental implant itself. So the patient was ready to remove that implant in order to get this treatment for their long-term and chronic condition. So in some instances, we have required the help of dentists to remove a particular implant like that. In most other cases, we've been able to deliver TMS without any issues. And I have asked some experts in the field in the past at professional events regarding this, and they also are on the same page that except in rare cases, dental or jaw implants should not be a major issue unless we know specifically that it's a ferromagnetic material and MRI is strictly prohibited. This is the only cause for concern. Effects of deep TMS on cognition. Yeah, that's an interesting question. So here again, it's more treatment related. So for example, if there's cognitive difficulty in something like depression, where people have memory problems or difficulty in concentrating, so that improves usually, but we have not used it much for the specific indication of increasing cognition in something like an Alzheimer's dementia or something like that. There has been some research with traditional RTMS which stimulates the dorsolateral prefrontal cortex, the region in the brain which is thought to be responsible for a lot of cognitive function. So here there has been some research on that. The results are a bit mixed, but we have not used it much, deep TMS much, for that specific indication. Is there any usefulness in PTSD? Yeah, so that's again an interesting question. So there's no formal approval in PTSD, but sometimes now TMS research is also progressing towards individual symptoms and individual problems. So there is some hyperarousal in PTSD which can be targeted by inhibiting networks on the right side of the brain. So we have not so far received many PTSD related cases, but there is a case for TMS if they are not responding to medication, because certain symptoms of PTSD, which are also common to other anxiety and other conditions, which can be targeted with TMS. So I hope that answers it. And yeah, so we have a question: is deep TMS effective for bipolar disorder or bipolar depression? So yes, we do use it for bipolar depression and we have seen good clinical efficacy. In mania, the use has been lesser. We have used it in a few patients, but there, as I said, we use the inhibitory kind of protocols and not the excitatory ones. Can patients opt for deep TMS if they don't want to take medications? Yes, very much that is possible. So here, yeah, so this is again, like I said at the start of the session, we have another, apart from the two options we had in our toolkit earlier, which were medication and psychotherapy. This is the third one in our arsenal now, right? So we can use any combination of these to help our patients. So it depends on the kind of the condition that they are presenting with. In some, if we feel in the clinic that medication would help them even if they are taking TMS, we give that advice. But yes, if medication is not an option and people want to prefer a biological but non-pharmacological or non-medicine alternative, TMS is very much an option for specific indications. It can't be used for everything, but with those specific indications, it is very much an alternative option, and we have used it in that context quite frequently. Yeah, next question is when to refer a patient of OCD for TMS in clinical setup? Yes, that's a good question. So OCD is by nature a very long-term kind of condition, and people usually, before they come to us, our common experience is that they would have tried quite a lot of treatments before us, and they would have gone to various doctors or they would have tried many different medicines. So again, here OCD, the context is similar to depression. So one reason is when medicines are not improving the outcomes, or when there is a limited improvement in outcomes of OCD, like the intrusive thoughts of OCD, the compulsive actions of OCD, like the hand washing and all. If they are only improving to a limited extent despite us trying enough medication for enough period of time, that would be one indication. Another indication would be intolerable side effects to medication. With medication, if we are not able to take the dose of medication to the required level, they are developing intolerable side effects, and there is another alternative that is required, then TMS is one alternative there. And another thing is if they are desiring a relatively quicker improvement, then TMS is an alternative that can be attempted. When say there is an important thing coming up, or we have I will try to narrate some of the common clinical contexts when somebody is joining a course and they have a limited period of time before that, or somebody is traveling abroad for migration and they have a limited time period before that, and they are desiring some quicker level of improvement, then that we have a good option in TMS. So the next question is it safe to use in children? It has been studied less in children, so we use with caution. We do use it in some children below the age of 18 years, but that's more of an off-label kind of use. And so far we have not had any safety concerns. The screening process and the safety related information is similar to what we do in adults, but we are more cautious when we give it. We do a higher level of scrutiny when we use it in children. But yes, we have used it in a limited manner in children below 18. Yeah, so regarding the referral of OCD to TMS in a clinical setup, do we strictly need to adhere to theoretical guidelines? I would say it is more of a mutual decision between a doctor and a patient. So even if the theoretical guidelines are not particularly one issue with this, so this is a nice question actually. So one issue with this is that there are not a lot of guidelines for TMS. Even if you see like Indian OCD guidelines and everything, TMS is not a major part of them, because it's a very relatively quite a new intervention. It has exploded in the last 4 or 5 years a lot more, and many of the international guidelines which have come are slightly maybe before that or just when TMS was coming out. So you will not find a lot of TMS related information in standard guidelines, but there is no our personal experience is that there is no such restriction that should be placed, because it's an alternative which is available, and between us and the patient, if it is suitable for them, it is a very much usable intervention, I think. A role of RMA, could you please expand on RMA? Any experience of TMS for movement disorders? Yes, good question. Yes, so we have used it, limited experience in our setting, but we have used the OCD related coil for some patients with Parkinson's disease. And we have around maybe 3 or 4 patient population in which we've used them for both. So the population presenting to us was the patients had problems of Parkinson's disease as well as some depression or anxiety or OC related symptoms. So we gave a combination kind of protocol in that, where we tried to address the symptoms of OCD as well as symptoms of Parkinson's. And in that we found a good level of success with symptoms like tremors, mainly tremors and rigidity. But the 3 main symptoms of Parkinson's are tremors, hands and various other parts of the body, shaking kind of sensations in different parts, stiffness in the limbs, and slowness of movement. So we found it to be decent level of effective for tremors and rigidity. So we have given in this particular movement disorder. Yeah, the cost of TMS for OCD is the same as for depression and for other conditions. It's the same in most setups, and it varies from setup to setup, but there's no difference for OCD specifically. Just that the number of sessions is more, so the cost might increase because of that. Otherwise, there's no difference per session usually. Next, so treatment resistant and non-compliant patients can really benefit. Yes, so to answer your question, this is the initial populations in which TMS was studied. So the initial effectiveness of TMS in depression. So if you go through some of the evidence, a bulk of the initial literature was all done in patients in whom 2 or more antidepressant medications were not effective. So this is the population in which the study of TMS actually started and was proven to be effective, and then it came onto the scene for later for even non-resistant and different kinds of depression and other problems. So yes, it is definitely a great option in treatment-resistant patients. Is it safe to refer for people with hypertension? Yes, very much. So this does not have any systemic side effects, and so far we have treated many people who have hypertension and diabetes and other medical illnesses. So yeah, there's no problem in treating a patient of hypertension with TMS. There's no issue. Where in India could we get RTMS training? Okay. So I think there was an earlier question about us doing training as well. So currently we are doing some workshops. So there are workshops, so we'll notify anybody with an interest. This account posts updates constantly. So we are starting with workshops, and we'll probably extend our training related programs soon. And I'm not aware of certificate courses or short fellowships, but there are frequent workshops in central institutes like NIMHANS or AIMS or Central Institute of Psychiatry in Ranchi, where one can attend and gain very valuable information. So, and these are by nature short, brief events lasting for 2 to 3 days, but they also give you hands-on experience. They let you handle a TMS machine, and they let you do these things. So yeah, so then you can attend these events. I think one is coming up in AIMS in October 15th or 16th. So yeah, those are the places where we would probably learn about this. So we have another question. Any efficacy for recurrent suicidality? So yeah, this is again, I don't think this is a very specifically studied indication, but in our clinic there has been one study on non-suicidal self-injury with a coil which we otherwise use for tobacco cessation. So in this coil we have found some effectiveness in reducing the urge to self-harm. So this we think is an important finding which merits further research, and we are in the process of drafting further research for these particular indications. And in recurrent suicidality, yeah, we've had some patients with recurrent depressive episodes in which suicidality presents, and we have had a very good response to the depression and suicidal thoughts in some of them. But yeah, the routine precautions apply, and there it's a decision made on risk benefit analysis. We discuss with the patient, we offer all the other options like an ECT or a hospital admission, and depending on the preferences and the feasibility, we do have some experience with TMS in patients who have had suicidal thoughts in depression, which have improved very well with TMS. Yeah, so what about patients who have had history of migraines? Yes. So yeah, we have given, again in this population, we have given TMS. In most patients, TMS did not trigger migraine episodes. In 1 or 2 patients it did, and we have had to change protocols there. It has happened, and there are some specific research related TMS protocols specifically for migraine. So for 1 or 2 patients we have given that as well. So there is that also. So you can treat migraines also with TMS protocol, but that's not as established as the treatment for depression or OCD. But yeah, there is a specific protocol for migraine also, which can be added to your regular depression and OCD protocols in order to benefit the patient even better. So this is about it. And yeah, any role in ECT resistant cases? Yeah, I mean, there could be a role because ECT is a generalized stimulation while the mechanism is slightly different, right? So in TMS we are using specific targets, and some symptoms might improve which have not improved in ECT with TMS because we are targeting specific brain regions. Again, we have had limited experience with this, but yeah, sometimes in cases of OCD where ECT was used and did not lead to much improvement, we have seen more improvement with TMS. Those patients had received some ECT in the past, which improved the suicidal part of their problem, but it did not improve the obsessive and compulsive symptoms. Those things improved much better with TMS, yes. So that would be probably one indication. But I feel like it is definitely worth trying in case it has not been tried for a particular patient in the past. So what is TMS dip and how long can it stay? Can you elaborate on that question, please? If you're asking about the effects of transcranial magnetic stimulation, the research consensus says 6 months to 1 year, and our clinical experience is somewhat similar to the research. But if your question was something else, can you please elaborate on that again? Yeah, extending question on migraine. Is TMS effective in migraine headache resistant to medication? So yes, there have been some studies on this, and there have been practical. There has been some practical experience on this in our TMS clinic and in other places. And yes, it can be tried for migraine headache resistant to medication. There are specific protocols for this, and it is definitely worth a try in resistant kind of cases. Yes, so I think, yeah, we have come to the end of the questions list, and if anybody has any more questions related to TMS, or if any of my answers was not clear or requires more clarification, please feel free to put it in the comments or questions section. Does TMS affect cognition negatively? Yeah, so no, it does not affect cognition negatively. We have 15 years of long-term data on it. No, it does not affect cognition negatively. And the effects of on cognition, even the positive effects, right now they are considered secondary to the improvement in depression or OCD, but there's no negative effects on cognition. In the long-term data, there are no long-term changes in memory or disturbances in memory or attention or concentration. So no, that's not a concern at all. Yeah, this is a good question. This has been asked to me in the clinic many times by patients who are apprehensive about long-term effects on their memory or concentration. But no, there's no negative effects. That should not be a problem. And even on a day-to-day basis, when the TMS is ongoing, because it is not something which involves any sedation or anesthesia, even on that day, people who come to us, they go back and drive. They work after a TMS session. They sit in our clinic and do work from home. Kind of they work remotely from our clinic. So the cognition, there's no problem either during or after treatment. There's no issue with that. So yeah, elaborating TMS dip. Yeah, thanks so much for getting back on that. Why symptoms of depression are worsening? So see, this can have many reasons. Usually depression is a multifactorial condition, like any other chronic medical condition, like say BP or thyroid problems or diabetes. It is a condition which the causation, many factors are involved. So if any of those factors is again acting in that particular situation, a depression can worsen. So with TMS, there is no worsening of depression in our experience. That does not usually happen. It never happens. And after TMS, how long the effects last, that can vary from person to person. So if somebody has a worsening after a few days of TMS, there can be many reasons for that. In that, we have to talk to the individual and ask them about what is happening at that particular period of time, and try to address that particular issue. Any use in ADHD? Yeah, so there is some literature on ADHD. We have also used it. So there is some evidence that stimulating the right side, some particular regions in the right side of the brain improves ADHD. But again, this is a preliminary indication. There's not as much evidence as is there for depression or OCD. But yes, in certain cases where maybe medications have been tried and behavioral and environmental modifications have been tried, it can be used. And yeah, so in those cases it is worth a try, where we can combine this. And if there's a comorbidity, especially like if ADHD is also co-occurring with depression or OCD or some other condition, then we can do a customized combination protocol with TMS, which can be quite effective for this. Are there any more sessions? Yeah, there are more sessions this week. You can keep following our page. There'll be more. There are 2 more sessions this week. Yeah, what about catatonia? Okay, so catatonia, we have not used it because this is more of an outpatient kind of an intervention. So we have not used it much with catatonia. I think their ECT is still the preferred option. But we have used it in quite severe levels of depression, where we have found good change in a matter of days. So yeah, this is about that. So yeah, we are getting a question on the difference between RTMS and Deep TMS again. Yeah, so I had addressed this earlier. So the main difference is that one of the basic aspects of TMS which is different from any other intervention is that very specific brain areas are being targeted for improvements. So here with Deep TMS, we are able to reach targets in the brain which are deeper than what we used to access earlier with RTMS, and that has the potential to increase the effectiveness. So we are finding new targets which we were not being able to stimulate before. So those targets are key to some of the networks involved in these conditions, and yeah, so the potential for improvement is more when we are able to reach such kind of targets. And we are getting some feedback. I'd like to thank you all for the wonderful feedback that you have provided. And I think we have like maybe 2 or 3 more minutes, so we have time for like 2-3 more final questions if anybody has any of those. Otherwise, I'm going to conclude in 2 or 3 minutes, and you can always get in touch with our Instagram, or you can DM or comment on posts of our Instagram account in case you wish to get any more information regarding this. So yeah, I think we have come to the end of, yeah, so we have just a last question. Yes, we have just the time for one question, I think. No, yeah, I might join the session on 14th. Yeah, that's still in the works. Is RTMS safe even if it doesn't work? Yes, it is safe because the stimulation is safe. It has been done over many years, and there are no serious side effects which are expected in most people in whom there is no prior risk factor like a seizure or a head injury or anything like that. So 100% yes, RTMS is quite safe. It is safer than most other interventions, even when there is not much response, which may happen in certain small percentage of individuals. Is there any material in the textual format that can be given across that is patient friendly? Yes, of course, we'd be very happy to provide that. I will communicate it to our team to provide any patient friendly material regarding TMS. Yes, that absolutely can be done, and we will keep posting on our Instagram page and all across all our socials also. We are on LinkedIn and YouTube and Instagram and Facebook, so we'll be posting information there as well. So yeah, I think we are out of time, and thank you so much for joining. If there are any more questions to our clinic or me, you can please DM them or comment on posts of our account, and we'd be happy to take any further queries. And thank you so much for joining today.